Next, we have Dr. Bini, a faculty of Regional Institute of Ophthalmology, who is dealing with angry eyes and angry patient, which is yet another common scenario we see.
Good morning. The problem with the ocular surface diseases are its chronicity and the recurrence and acute attacks. The aim of the treatment should be to decrease the recurrences or acute attacks and to prevent the complications. The first thing when a patient comes with red eye is to rule out intraocular diseases. This was a patient, 26-year-old female, came with the symptoms of allergic conjunctivitis, and patient had history of decreased vision for last 2 to 3 years. And on examination, there was conjunctival scarring and signs of chronic papillary reaction, and the cornea is having this subepithelial scarring and punctate epithelial erosion. And on examination, and there was patient's skin showed this atopic dermatitis, and topography showed keratoconus. This was an atopic keratoconjunctivitis. This was 9-year-old boy with itching and redness recurrent attacks, and there were giant papillae in the upper tarsal conjunctiva and one shield ulcer in the other eye. This was vernal keratoconjunctivitis. So we can identify this allergic conjunctivitis with the papillary reaction. The problem with this allergic conjunctivitis is its recurrence and chronic nature. So always counsel the patient about the nature of the disease and possibility of recurrences and acute attacks. So coming to the treatment part, better to avoid allergen, but it is not always possible. We can start with the dual-acting agents like olopatadine and alcaftadine. And in each and every acute attack, it's better to start with the topical steroids if the patient is not steroid responsive patient. And the main thing is to very slow tapering to prevent the further recurrences. And if it is not controlling with the steroids, you can, if again recurrences occur, then you can add topical immunomodulators like cyclosporin or tacrolimus. If again not controlling, we can go for supratarsal steroids like triamcinolone. The other things to remember are always treat the rhinitis associated with the allergy, because this acute rhinitis can again cause the precipitate this acute conjunctivitis. Tell the patient to avoid eye rubbing because that can cause muddy conjunctiva and development of keratoconus. Always monitor steroid response also. In severe cases of allergic conjunctivitis, there can be associated dry eye that is also to be addressed. This was a 33-year-old female presented with bilateral redness. You can see this small staining areas in the conjunctiva that represent flictin associated with the meibomian gland dysfunction. This was a case of meibomian gland dysfunction. So in the other eye, you can see this small infiltrate and superficial vascularization. Again, this meibomian gland disease also can recur and cause this acute attacks. So we can treat these patients with topical antibiotics, topical steroids, and systemic doxycycline for at least 6 weeks to prevent the frequent recurrences. This was manifestations of flictin. You can see this conjunctival small ulcer or this vesicles. This can be due to allergic to bacterial antigens like tuberculosis. If there are more recurrences, you can investigate this patient for tuberculosis or worm infestations. The problem with the dry eye is its multifactorial etiology, associated inflammation. Again, this inflammation can also recur many times, and there is lack of correlation between the signs and symptoms. Some patients can have dry eye even without any signs, and there can be coexistence of aqueous deficient and evaporative dry eye, and disease is mostly it's chronic. Coming to the treatment part, in case of evaporative dry eye, start with the artificial tear with more retention time like polyethylene glycol or sodium hyaluronate. This aqueous deficiency dry eye treat according to the severity. In case of mild dry eye, you can go for this CMC or HPMC. In case of moderate, you can increase with high viscous agents. And in case of very severe disease, add drops with osmoprotectants and electrolytes to decrease the surface damage. If there is associated lid abnormalities, always treat that also. If inflammation, we can add steroids and cyclosporin. And we can add systemic doxycycline also in case of recurrent inflammation. In case of artificial tears, try 2 to 3 artificial tear one after the another. Instruct the patient to continue with the most comfortable one for that patient. This was a 46-year-old male, came with redness bilaterally for last 2 weeks. This patient had history of using anti-glaucoma medications for last 2 years, but before 1 month changed to another molecule. So this was a brimonidine toxicity. We changed the molecule to another one and stopped brimonidine. This one was the picture after 2 weeks. This was a bilateral case of episcleritis, and this patient, because it was bilateral, we investigated this patient for systemic diseases. There was 20 to 30% of the patients associated with systemic diseases in case of episcleritis. We can treat these patients with artificial tears or NSAIDs, but if it is not resolving, we can go for topical steroids. In this case, you can see the deep scleral vessels are congested and there is bluish discoloration of the conjunctiva. This was a case of scleritis. There is stepwise management for the scleritis, which include topical steroids, systemic NSAIDs, systemic steroids. And in case of vision-threatening complications like this, you can go for high-dose topical systemic steroids like methylprednisolone, and systemic immunosuppressives should be started in consultation with the rheumatologist. So the bacterial conjunctivitis will have a short course, but in case of adenoviral conjunctivitis or any viral conjunctivitis will have a prolonged course. So you can see the different manifestations like pseudomembrane chemosis or subconjunctival hemorrhage. In the treatment, there is no proven antivirals. So you can give this try with the povidone with dexamethasone. It's in the trial phase. The indications of steroids are severe inflammation, uveitis, membrane or pseudomembrane formation, and subepithelial infiltrate involving the pupillary area. This was a 65-year-old male, came with redness for 1 month. Patient had history of this excision around 2 years back. This patient, the clinical diagnosis was recurrent OSSN. So we started this patient with a topical interferon alpha, and this was the picture after 2 months. This is 13-year-old girl came with this conjunctival ulcer. Outside it was treated with topical steroids but not resolved. So we did scraping and the fungal hyphae was positive for KOH. So the patient's symptoms and signs resolved well, but the differential diagnosis include Behçet's disease and HSV conjunctival geographic ulcer. So when a patient comes with red eye, always rule out intraocular diseases, always counsel the patient about the recurrences, chances of recurrences and chronic nature and long duration medications, and always monitor intraocular pressure if the patient is on topical steroids and need a regular follow-up. Thank you.
So red eye, even though it is a small symptom, it can have a multi-diagnosis. So madam has shown so many case scenarios and the approach to each one. Thank you, Dr. Bini madam, for such a detailed